The following podcast is part of a certified educational activity titled Selecting and Sequencing Targeted and Immunotherapy Regimens for RCC. How will the latest evidence impact treatment decisions for my patients? Access the entire activity and complete the post-test at peerview.com/XZJ860. Downloadable slides and practice aids are also available.
Okay, well, welcome everyone. We're going to be talking all about kidney cancer across lines of therapy. The title is Selecting and Sequencing Targeted Immunotherapy Regimens for Renal Cell Carcinoma. We have several panelists with us today, my dear friends Nazar Tanir and Tian Zhang. And this is a general overview of what we want to discuss. So in broad strokes, we want to discuss treatment in the perioperative setting. There's obviously been a lot of changes there with the presentation and publication of data from Keynote 564. We'll talk about frontline therapy in the advanced setting and the merits of IO versus IO-TKI, subsequent line settings, which now becomes a bit of a controversial area, and we'll wrap up with some discussion of AE management. So first, I'll turn it over to Dr. Tanir, who's a mentor to, I would say, virtually everybody in the kidney cancer space across the country. He's a professor in the Department of GU Medical Oncology at MD Anderson. Dr. Tanir, would you like to walk us through dual immunotherapy?
Thank you, Monty, for the kind introduction, and thank you all for coming here. First, before we get to this, I would like to dedicate my presentation to a dear colleague and friend, Dr. Christopher Wood, who unfortunately passed away this morning, untimely death. He is a giant in the field of urology and urological oncology, a colleague, a mentor to so many, and he was a really tour de force here with KCA, and we're here now because of his efforts. But his legacy will live on through all the people that he trained over the years at MD Anderson and all the lives that he touched in the world, operating on people with kidney cancer. So we'll start with an update on the results of CheckMate 214. This is one of the largest phase 3 trials in first-line therapy of patients with advanced kidney cancer, clear cell, and it's also the one with the longest follow-up. And here on the slide, you see the treatment schema. Patients with advanced clear cell RCC were recruited to this trial in the first line, and they were stratified by IMDC risk score and region. And you see here on the slide the randomization 1-to-1 between the Nivo-Ipi at the doses and schedule noted here versus sunitinib at the standard dose and schedule. There were the primary endpoints for this phase 3 trial, the CheckMate 214, were 3 co-primary endpoints with PFS, OS, and objective response rate in patients with intermediate and poor risk disease. Secondary endpoint, PFS, OS, and ORR in the ITT, and then the exploratory PFS, OS, and ORR in the favorable risk disease. And here on this slide now is the results for OS and PFS at the different milestones for the study. In the first column, you see the minimum follow-up, 17.5 months. That's when we first presented the data in September 2017, and the publication in New England Journal of Medicine in March 2018, and then 30 months minimum follow-up, and 42 months, and then the latest one, 48 months minimum follow-up. And as you can see here, the results are showing that there is improvement in OS for intermediate risk, poor risk. And you can see the hazard ratio has really remained about similar here, constant here, around 0.63 through 0.65 across the time points here. And then here for PFS, although the difference between the two treatment arms did not meet the statistical significance as pre-specified in the trial, but you can see the hazard ratio here has improved over time to 0.74, and you'll see later how this translates to the landmark analysis, where we can see the results actually are even more impressive. So the value of giving dual immune checkpoint inhibitors as first-line therapy with a PD-1 blockade with Nivolumab and a CTLA-4 blockade with Ipilimumab is, in addition to OS, which is obviously the most important endpoint for any trial, for patients with cancer is the opportunity to have a treatment-free interval. And this is what you get with Ipi. And here are, on these two panels, patients who achieved CR with Nivo-Ipi. And here are patients who had intermediate risk, poor risk. And you see here, this is a swimmer's plot showing individual patients here across time. And the open circles are the time to first response. The dark blackened circles are the ones that had event and the time of that. And then the arrowhead are ongoing responses. And in the top panel here on the left, you see patients who were still on treatment with Nivo-Ipi, and then later on maintenance Nivolumab. And here are patients, and you can see here the important thing to show here are these long bars here, darkened blue bars, patients who were able to stop therapy. These are patients here who achieved the CR and were off therapy and did not require and continue to have a response. And here, the same thing here for patients with favorable risk. And you can see here in those, among those 16 complete responders, again, here are patients who were able to stop therapy and never received subsequent therapy. And here are a couple of Kaplan-Meier curves for OS. And this is now data with 5-year minimum follow-up. This was presented at ESMO. And you can see here for the first panel here, the patients with intent to treat. And here are this is the population with intermediate risk, poor risk, and here a favorable risk. And as you can see here for OS, there is a significant difference between the two treatment arms. And you can see here now that after minimum 5 years of follow-up, Nivo-Ipi produced a median OS of 56 months versus 38.4 months median OS with sunitinib, and this has a hazard ratio of 0.72, so that's a significant difference. And for the intermediate risk, poor risk, as you saw initially on the table, the median OS for sunitinib is constant at around 26 months, and here is the median OS for Nivo-Ipi for patients with intermediate risk being around 4 years. And you can see here, at 5 years, here the landmark analysis is 43% in patients with intermediate poor risk are alive versus 31%. And for the favorable risk, as you will see later on from Dr. Powell's presentation, for favorable risk, the combinations of Nivo-Ipi, or as you will see with the PD-1 antibodies plus a TKI, for that favorable risk, there is inconclusive evidence to show survival advantage for a combination versus the single-agent TKI. However, as I'll show you later, there is now data to show that even among the favorable risk patients, there is benefit over time for the experimental arm here of Nivo-Ipi. And so this is the same couple of markers for PFS. And then here we're looking at probabilities and landmark analysis, again, at that 5-year minimum follow-up here. And you can see for the ITT as well as intermediate poor risk, there is around 31% of progression-free survival. You see here, there is almost a flattening or a tail or shoulder at the end of the curve here for the Nivo-Ipi treated patients compared to sunitinib arm, which continues to drop to the x-axis. And you can see here the difference between the two treatment arms vis-a-vis PFS at this 5-year landmark analysis. And you can see here for favorable risk, even though the sunitinib arm had a longer PFS of median 28.9 months versus 12.4 months with Nivo-Ipi, and we know that the patients here had a 52% response rate versus a response rate of 30% with Nivo-Ipi. At 5 years, there's a higher proportion of patients who are progression-free with Nivo-Ipi compared to sunitinib, and you'll see now the responses on the next slide here with a minimum 5-year follow-up. And you can see that for intermediate risk, poor risk, and ITT, the response rate is around 40% for Nivo-Ipi versus 32% here in the ITT, 27% in intermediate risk. For favorable risk, the response rate with sunitinib is 52%, but this is draw your attention to the important CR rate, which is really a goal for us to achieve, hopefully, a durable CR and break the cure barrier. The CR rate is important, and here for the ITT, 12% versus 3% 11 versus 2% for intermediate risk, poor risk. Even in that favorable risk category, the CR rate with Nivo-Ipi was 13% versus 6% with sunitinib. So I think here, this is the important here in the green box here, that a higher proportion of patients achieve CR with Nivo-Ipi versus sunitinib regardless of risk. And more patients achieved, and you can see it here at the bottom, ongoing responses. A higher proportion of patients with Nivo-Ipi had CRPRs that's ongoing compared to sunitinib. And the median duration of response was notably higher with Nivo-Ipi, as you can see here, versus sunitinib, even in patients with favorable risk. Now, what about treatment-related adverse events? I think it's important to recognize that Nivo-Ipi can produce immune-mediated adverse events, but these are usually, they occur in the first 6 months of therapy, and over time, these decrease, including the grade 3 and 4 and grade 1 and 2 over time. So safety here at 5-year minimum follow-up shows that Nivo-Ipi, the safety is consistent with no new signals of safety over time, and the comparable rates of treatment-related AEs of any grade occurred comparably for both treatment arms, but the grade 3 and 4 treatment-related AEs were lower, 48% with Nivo-Ipi versus 64%. And then the quality of life benefits, I think, will continue to favor the combination of Nivo-Ipi compared to sunitinib in patients with intermediate risk and poor risk, as well as the overall population. So the take-home message here for dual immunotherapy as first-line therapy for patients with advanced clear cell RCC is that with a minimum 5-year follow-up, and this is the longest follow-up of any phase 3 trial in first-line therapy, CheckMate 214 continues to produce benefits and resulting in durable responses across all IMD's risk groups. There is a potential, as I showed you, for treatment-free interval, which is really important for patients, and the toxicity is highest in the first 3 to 6 months. We saw that even in patients who have favorable risk, there is a higher proportion of patients who are alive with minimum 5 years with Nivo-Ipi versus with sunitinib. So this is a patient of mine that I had the privilege of treating several years ago. She came to MD Anderson. This is a 53-year-old Caucasian woman who presented with increasing fatigue associated with dyspnea, cough, and had a palpable right flank mass. And her past history was contributing for psoriasis, which was minimal and managed. And evaluation showed on CAT scans a 10-centimeter mass in the right kidney with IVC tumor thrombus involving the right renal sinus and calyceal system. She had scattered pulmonary nodules consistent with lung metastasis and also a clustered left supraclavicular lymphadenopathy suspicious for metastatic disease. She underwent a right radical nephrectomy and IVC thrombectomy, and the pathology showed a 12.5 centimeters clear cell renal cell carcinoma with extension into perinephric adipose tissue, renal sinus, renal vein, and the IVC. And this puts her at stage with PT3C and 0MX, so stage 3 disease. But she had metastasis already to the lungs and lymph nodes, so she had stage 4 disease. And 6 weeks post-operatively, she had new and enlarging bilateral pulmonary nodules and liver metastasis. Her lab work showed anemia, but otherwise was normal. So she had, by IMDC criteria, she had intermediate risk disease with 2 risk factors. Here is her scan. On your left here, the scan at baseline we obtained. She had liver metastasis, as you can see pointed in the green arrow, and she had also lung metastasis noted. So we enrolled her on the CheckMate 214 study back in July of 2015, and she was luckily randomized to Nivolumab and Ipilimumab. She developed acute thyroiditis after the first cycle, but tolerated it very well otherwise. And after her second cycle, she developed pneumonitis and was hospitalized and was treated with high-dose corticosteroids. And we were able to taper as an outpatient with prednisone, and we were able to discontinue the prednisone. And we were able to give her a third cycle. And unfortunately, after the third cycle, she developed again pneumonitis, and this time she also had acute hepatitis with elevated serum transaminases, as you can see here, the numbers. And so we again restarted her with high-dose corticosteroids, and she was able to be discharged and tapered her prednisone over 6 weeks, and she completely responded to steroids with resolution of her pneumonitis and hepatitis. We'll have a chance, I think Dr. Pal will go over some of the management of adverse events associated, like we call them immune-mediated adverse events associated with this therapy, which is very important for the practitioner. But we decided after 3 cycles to stop the treatment, and she was taken off protocol treatment, and that's all she had, 3 cycles of Nivo-Ipi. Again, to illustrate the point I made in my presentation about the value of producing treatment-free interval. So that's all she had for treatment, only 9 weeks of therapy with Nivo-Ipi, and she remains in complete response 6 years later, and here are her scans now.
Nizar, let me ask you a question. How have your colleagues in the community evolved in terms of managing IRAEs? This is a complex case. I think it's quite fortunate that she was under your watch, and I think it must have been a difficult decision to give that 3rd dose of Nivo-Ipi given her pneumonitis. Are you seeing that practitioners in the community are learning how to manage these toxicities and bringing patients in an appropriate time frame?
Yeah, I think obviously it's a learning curve. Initially, even us at academic centers, when we first designed the Nivo-Ipi, the CheckMate 214 trial with the 4 cycles of Nivo-Ipi, followed by maintenance, and the complexity of management of these patients with IMAEs. It takes time to really acquire the skills, and I think what we have done here at MD Anderson is, and this is a while back now, it's very important to communicate with patients directly, have your nursing staff and the physicians communicate with the patient. And I think this also applies for people, the community oncologists, that really be in touch and follow up when you give them the treatment, follow up with the patients. And so we have at MD Anderson now an app where we have alerts directly sent to us in real time to the treating team, myself and my PA and our nurse, where we respond quickly to what they experience. I think this is why it's important to really know in real time quickly if the patient is in trouble and get them to come when they have still grade 1 or grade 2 adverse events rather than wait and then they end up in a local emergency room with a grade 3 and 4 and they get hospitalized and get sick. So I think it's important really early timing, recognition of the adverse events and initiation of strategies to mitigate the adverse events quickly. Like we said, high-dose steroids here is really important.
So we're going to jump forward here to other options that patients have in 2021 now, because certainly this is an evolving landscape. So I'm going to jump into a synopsis of all the TKI and IO combinations that are available in this setting. And rather than showing you each one of the schemas, we only have an hour to go through everything. I'm going to sort of generalize here. And although we can't do cross-trial comparisons, the designs of these studies lend themselves to at least some degree of comparability, because they all utilize the same sunitinib control arm that was used in CheckMate 214. You can see a TKI plus IO used in the experimental arm, albeit at varying doses and different strategies. So let's go through these together. So this is the Keynote 426 study. Again, just a quick overview of the study design and data, axitinib and pembrolizumab versus sunitinib therapy. And if I can highlight some of the data here, what you can see in the context of axi-pembro is a survival advantage over sunitinib therapy. This hazard ratio has actually evolved over the course of time. So to Nizar's point, in the context of Nivo-Ipi, you've actually seen a fairly consistent hazard ratio over time. With axi-pembro, it's actually increased from the time of initial presentation from really kind of a microphone dropping 0.53 to 0.73 in this study. The difference in progression-free survival, everybody has a different perspective on this. And I thought this was quite modest, 11 months versus 15 months. But this is where the data sits currently. In terms of response rates, this is really, I think, one of the benefits that one might argue with the combination of TKI-IO versus IO-IO. The response rate overall at 60% is higher. the CR rate 10% with this particular regimen, and that actually has increased over the span of time. And this has the longest follow-up out of any series to date of TKI plus IO here. So reflecting on our schema once again, one of the other elements that we can discuss in the context of this trial is some of the discontinuation data. A big question, not just in the context of Nivo-Ipi, but in these emerging TKI-IO combinations, is when you can actually withdraw treatment. And so this was data that Betsy Plimick presented at ASCO GU not long ago, and this reflects patients that have discontinued therapy with Pembrolizumab at the 2-year mark. And you can see that there are very few events occurring in terms of survival on the left-hand panel. A modest number of events occurring in terms of progression-free survival on the right-hand panel here. So, it's hard to know what to do in that particular setting. I take this data as suggesting that that may be a reasonable option. Again, we're really going to do sort of a highlight of the existing data. This is a data set that I actually usually lean on in my day-to-day practice, and that's CheckMate 9ER. So this evaluates the combination of cabozantinib and nivolumab versus sunitinib therapy. As you look to the data for overall survival, the hazard ratio in this study was 0.6. Median progression-free survival doubled here from 8.3 to 16.6. One of the things that isn't emphasized on this slide is the dosing regimen that's used. So many of us in the room are familiar with using cabozantinib in the second and third line setting at 60 milligrams. I think the investigators associated with this study, I wasn't one of them, made a very wise decision to actually bring that dose down from 60 milligrams to 40 milligrams. In my opinion, I think that makes this regimen leaps and bounds more tolerable. In terms of response rates, you can see some comparability here, 55.7% versus 27.1%. These numbers not strikingly different from the data that you saw with Axi-Pembro, but again, I think a more impressive difference in terms of progression-free survival. With more extended follow-up in the intention to treat population, you can see these numbers holding to a greater extent. Progression-free survival hazard ratio here, 0.52. For overall survival, numbers holding at 0.66. So I would say that, clear separation between the curves. Clearly, this is an effective regimen. Now, this is a regimen that, in my opinion, is maybe a little bit more controversial. The data here is impressive when you look at this combination of Len-Pembro, which was compared to sunitinib, as well as Len-Ev in the context of the CLEAR trial. You see here a response rate that's double with the combination of Len-Pembro, 36% versus 71%. CR rates here impressive, approaching 16% in patients receiving the combination of lenvatinib and pembrolizumab, and a striking difference in terms of progression-free survival with a PFS of 23.9 months versus 9.2 months with sunitinib. So impressive data, but one thing that's important to point out here is that those of you in the audience treating renal cell carcinoma have gotten used to this dose of lenvatinib at 18 milligrams in the second line setting. I've tinkered around with different dosing strategies. In the context of the CLEAR study, that dose is actually increased to 20 milligrams. So I certainly think that issues of tolerability might rise to the fore, and we'll discuss that in just a moment. Pembrolizumab and lenvatinib did demonstrate a significant improvement in overall survival as well. This is reflecting a hazard ratio of 0.66 here. I'm not too concerned about this crossover that you see in the curves. There's very few events reflected at these late time points here. I did want to harp in on this issue of dosing and tolerability and the impact that it may potentially have in terms of quality of life. Again, quality of life data is challenging to interpret. Across all of these studies, you're looking at different metrics. There's different time points that are being assessed. But just to make the point between the two regimens that I think have come to the fore more recently, CheckMate 9ER and CLEAR, in the analyses from the CLEAR trial, you can see that there's no difference across at least some of the metrics that have been reported thus far. There have been some further dissections of that, as you can see in this forest plot down here. Maybe some symptoms that are improving, others worsening in the context of this combo. To me, my interpretation of the CheckMate 9ER quality of life data was more clear-cut. Across time, across the landmarks assessed, and across the different scales, you see that there's improvement in broad terms with cabo-nivo versus sunitinib therapy. So we're going to change up the discussion a little bit here. What if she'd elected to pursue therapy with an IO-TKI combination? How can we counsel this patient to really help with this discussion around these different treatment options? Certainly this entails some conversation around risk status, quality of life goals. Tian, maybe I'll turn it over to you for a second. How do you walk that patient through the discussion of IO-IO versus IO-TKI?
When this type of patient comes into my practice, and I always talk about all of our treatment options together and give them all the options. And I think really helping them make a shared decision with the oncologist is very important. And in talking about all the studies, I tell them none of these trials have really been compared head to head. So as we're looking for an immunotherapy-based combination, and really talking about goals. Are we looking at really trying to intensify a pure immunotherapy combination up front, and then a maintenance Nivolumab sort of on its own, perhaps less toxicity in that setting? Or are we looking for early disease control, right? One of the differentiators, I think, of the IO-TKI combinations is that we can really have some earlier disease control and better progression-free survival intervals up front. And so that's a differentiator in my mind, and what I would help that patient talk through. And their quality of life, I have a hesitation to really delve deep into quality of life, especially because when a severe immune-mediated adverse events hits, this can really change how a patients feel chronically in their lifespan. So that's hard, and from a cohort's perspective of comparing the treatments on their own for populations versus talking about it to the patient in front of us, right? So from that perspective, I will talk through, these are the side effects, here are how we manage, and we'll get you through. I really thought Nizar's point earlier was quite valid in terms of getting patients to understand the treatment toxicities early, identifying them, and then helping them advocate in an earlier setting to get the right management.
So Nizar, excellent, Tian. Thank you for that. And there's a very interesting question that came in from the audience here. And Nizar, I'm going to direct this one towards you, and I'll just kind of start with my perspective on it. I'm primarily using Cabo-Nivo in my practice. I've had several colleagues in the community using Len-Ev, but taking the approach of actually modifying that starting dose. So instead of starting with 20, starting with 12, starting with 14, starting with 10, my perspective on that is we don't really know what benefit that's rendering to the patient. I mean, what is your advice in that context?
I agree. I think if you're going to start Pembro-Len, the dose of Len that we should prescribe is 20 milligram. I mean, obviously, this is the data from the CLEAR study. If you make the decision to start Pembro-Len, you believe that the patient is going to tolerate it, I think you should start it with the 20 milligram. And I look at it as a loading dose. I think you can start with a 20 milligram, and if the patient a month later is not tolerating the 20 milligram, then you can give them, you can interrupt and dose reduce to 14. But you should start all your patients on 20. I don't think we have data to really predict what will the response and the benefit be if you start with 12 or 14, as you said. So I would start with 20.
I couldn't agree with you more. So I think that, again, if you're going to put that patient on frontline therapy, you're really sort of committed yourself to trying to replicate to at least some extent the data that we're seeing in these phase 3 trials that we presented, so sticking to that starting dose is really key. I have a lot more flexibility in the second and third line setting. Maybe we can chat more about that. I wanted to shift gears and actually talk about this slide that we have up here. And, this is up here for your perusal for the audience, but I wanted to kind of talk through how you differentiate toxicities. And so, Nizar, let's imagine for a second that patient that you presented, was not on Nivo-Ipi, but developed autoimmune hepatitis in the context of, let's say, Axi-Pembro. How would you kind of differentiate what's driving the hepatitis there?
I think, the good thing about Axi, it has a short half-life of 4 hours. So if they have any toxicity that is like you show here in your Venn diagram with an overlapping toxicity, whether it's diarrhea, fatigue, you can, or elevated liver function test, you stop the TKI, and then if in a few days the adverse event in question improves, then it's the TKI most likely. If it doesn't, then I think definitely the patient will need to be treated with steroids. So obviously it all depends on the severity. Now obviously if somebody comes in with 15 bowel movements, this is immune-related colitis, and that they need to be hospitalized for supportive care. And then at MD Anderson, we would get a colonoscopy on these patients. Of course, we get stool studies, we get colonoscopy and biopsies, and if we see immune-related colitis with lymphocytic infiltrates, we start steroids right there. So I think it depends on the severity, but I think this is where, maybe an agent that has a short half-life gives you that, day or two to really figure out if it is the TKI. And this is where I think axitinib, compared to other TKIs, has a shorter half-life, and you can quickly respond to that situation.
Got it. Yeah, and Tien, I'm going to ask you the same question, but maybe in the context of Cabo-Nivo, where you don't necessarily have that advantage of the short half-life. And for those in the audience, Tien is the national PI on the PDIGREE study. I'm hoping we'll be able to touch on that today, but it's a trial that looks at Nivo-Ipi up front and uses sort of a risk-adapted approach to utilize Cabo as an adjunct to maintenance Nivo for selected patients. So, in that setting, Tien, let's say, you had Nazar's patient who developed autoimmune hepatitis while on Cabo-Nivo. How do you sort of tease apart the toxicities there?
Yeah, thanks, Monty. I appreciate the plug for PDIGREE. We'll talk about it here shortly. But, for cabozantinib, where the half-life is quite longer than axitinib, I would still stop it first. I think the sort of same management, because we can stop the daily treatments, but we can't stop, an immune-mediated effect as quickly as just holding drug with an oral TKI. So certainly stopping Cabo early and then sort of monitoring. We've been doing this on PDIGREE for quite a while, and really kind of monitoring that patient through the first 3 to 4 days. If the diarrhea is not improving, that's when we would advise the sites to go ahead and start their steroids. Generally, these are, and the hepatitis, if the liver functions are not improving, then we would start the steroids. So generally, we can tease out which of the drugs is at fault here, but certainly jumping on stopping the TKI first, then adding on the steroid in the correct context, as long as the patient's stable. I fully agree, if a patient's unstable, then they should be hospitalized. We should start the downstream management quickly.
Excellent. Well, I've left this slide up on the screen just for your perusal. I think this offers a nice summary of some of the frontline data sets that Nazar and I have outlined here. And I think Nazar made a compelling case for the data for Nivo-Ipi from CheckMate 214. My frontline preference these days is Cabo-Nivo, based on some of the quality of life data that I showed you, based on my experience, using the Cabo 40 dose, response rate, et cetera. I think that a reasonable case can be made for several of these therapies, but I think one of the tenets that we've highlighted is, know how to manage the toxicities, and also, stick to those starting doses if you're using any one of these combinations. So Tien, maybe you can give us a little update on PDIGREE. How are things going while we're getting feedback on this question?
Sure, we're about halfway accrued, and it's going strong. Thanks from many of the investigators around the country, some of whom are sitting in this room. But we are, very positive about it, and it is only, I'll show here shortly, but it is one of the only phase 3 frontline trials currently accruing.
I was going to echo that sentiment. I think it's one of those studies we can all get behind while we have this pause amongst many of the frontline studies out there. So what about the refractory setting? I'm just going to kind of keep the dialogue going here and talk through a couple of different options. So this particular patient that Nizar had gone through progresses through frontline therapy. She responds with mild adverse events to Nivo-Ipi. At 12 months, she has a new pulmonary nodule. She switches over to therapy with cabozantinib. She tolerates it well for a period of time. Disease remains stable for about 9 months, and then she has a new liver lesion, so cabozantinib is discontinued. So this is the data that I was referring to earlier. My clinical experience, suggests that Lenvatinib is one of those regimens that can be, challenging in terms of toxicity management. So, one of the trials I was very interested in running was this one here, which looked at Lenvatinib 18 versus Lenvatinib 14 with Everolimus. And this took patients who were in the second line setting. And one of the things that you see here is that this was a non-inferiority study. One of the things that we deemed from this analysis, which was based on response rate, not what we're showing here, which is PFS and OS, is that the Lenvatinib 14 regimen was not non-inferior. So that means that, the suggestion from the study was to stick with Lenvatinib 18. And you can kind of see that. I picked this slide because you can see that reflected here to some extent. You can see the Lenvatinib 18 milligram dose sort of edging out the Lenvatinib 14 milligram dose in terms of progression-free survival. In terms of overall survival, it looks to be fairly balanced. So Lenvatinib and Everolimus is an option that we've had at our disposal for some time. It's something that I still use in the salvage setting. This is a data set that I think we really need to focus on communicating to our partners in the community. There's a lot of TKIs already out there for renal cell carcinoma. This is a new kid on the block, but one that I think is highly effective in the refractory setting. And this trial, TiVo-3, which I was really proud to be a part of, really does reflect an effort that represents a pathway that's specific to patients who have progressed on TKI and IO-based therapies. So the study schema, as you can see here, took patients who had failure of 2 to 3 prior regimens. Patients were randomized to Tivozanib, which is given at 1.5 milligrams oral daily, 3 weeks on, 1 week off, or therapy with Sorafenib. And what you see in the context of this study is a significant advantage in terms of progression-free survival. We're showing you some of the updates here with a response rate of 23% with Tivozanib versus just 11% with Sorafenib. And, Nazar was pointing out some tails on the curve for the CheckMate 214 data. Smaller numbers here, I'll confess, but, I am seeing, sort of a striking distance between the curves at some of these distal time points, which I think is quite encouraging. Now, if you think about the mechanism of action of Tivozanib, it's a very potent, specific VEGF inhibitor. So, for instance, in my patient population where I'm using Cabo-Nivo up front, I'm using that sort of multi-kinase approach in the frontline setting. I think it maybe makes sense to hone in with an agent like Tivozanib. Many have asked, well, is this actually different from Axitinib, an agent that we've had in the second and third line setting for some time? And, one of the things that you see represented here is this very nice analysis that Brian Rini presented at ASCO GU this year. And it distills the fact that in patients that have previously received Axitinib therapy in the context of TiVo-3, there's still an advantage with Tivozanib over Sorafenib. You wouldn't have expected that if these agents were completely identical. So I think there's certainly some distinctions between Tivo and Axi. And this really drives home the point that Tivozanib is a very well-tolerated therapy. I think it's reflected in the volcano plot that you see at the bottom. When you look at some of the relevant side effects in this patient population, diarrhea, hand-foot syndrome, nausea, vomiting, rash, etc. And this was my experience participating in the clinical trial as well. Saw that far less with Tivozanib than with Sorafenib. The table on the right-hand side articulates rates of dose reduction, better with Tivozanib, dose interruptions, dose continuations, both better with Tivozanib. So a really strong argument suggesting that in this salvage setting, Tivozanib really should kind of move to the fore as one of our preferred therapies. And there is some emerging data that I want you all to consider regarding the combination approach. The data from the combination of Tivozanib and Nivolumab looks quite compelling. I won't dive into the details, but I'll leave this slide up here for you. And critical that we all consider enrollment to TiNivo-2, which is a study that I think really addresses an area of unmet need, which is going to take patients who have received prior immunotherapy and randomize them to either Tivozanib or Tivozanib and Nivolumab. This is another new kid on the block. It's probably a little too early to talk about this agent in a clinical context for RCC, although it has applications in diseases like VHL syndrome. But this is Belzutifan, and this is data from a single-arm study that was just published in Nature Medicine not long ago. And what you can see with Belzutifan in a fairly heavily pretreated population is an impressive response rate of 25%. Median progression-free survival, 14.5 months. This waterfall plot seems to be getting a bit better over the course of time. You're seeing these responses deepen, which I think is the nature of the drug, but it'll be interesting to follow this along. And I'm going to turn it over to my dear friend Tian Zhang, who is an associate professor at UT Southwestern, just made that transition from Duke.
Thanks so much, Monty, and welcome to Texas, everyone. Happy to switch gears a little bit and think about sort of what's next on our landscape for kidney cancer. Wanted to switch gears and talk a little bit about the adjuvant setting, and permit me just to sort of think about the adjuvant setting for a moment. Post-surgery, your patient has had their nephrectomy, and you're thinking about what to do next, and in this space. we're really thinking a lot about balancing risk and benefit ratios and how much your treatment is adding. And so certainly benefits could be that we're preventing disease recurrence and prolonging overall survival potentially, but the risk of treatment, and when a treatment has a high adverse event profile, then we're thinking a lot about the toxicities in that setting, the cost implications of the treatment, and any inconveniences of the treatment. So instead of showing you all the data that we've had for the TKIs in the past decade or so in the adjuvant setting, suffice for me to sum it up in this particular slide in terms of thinking about that risk-benefit ratio for adjuvant sunitinib, which we had approved about 4 years ago. And so for sunitinib, for a lot of us, and many of you in the audience are thinking about this in the adjuvant space, the toxicities of a year of sunitinib often outweigh the potential benefit of extending disease-free survival to time intervals. And so when and if it was recommended, sunitinib was often for patients who are younger, who are maybe at a higher anxiety about their disease recurrence. So in that setting, we have multiple phase 3 adjuvant trials now with immune checkpoint inhibitors, many of which are currently ongoing, so including Prosper, Rampart, CheckMate 914, as well as Emotion 010, and then Keynote 564, which we saw the data for in the past year. So high-level look at Keynote 564. This was an adjuvant study, phase 3, randomizing patients to either treatment with Pembrolizumab or placebo. And we did see an improvement in disease-free survival intervals, here shown on the left, with an improvement of median disease-free intervals for Pembrolizumab here, with a hazard ratio of 0.68, and this was a 2-year median follow-up. Now, we did not see a statistically significant improvement in overall survival here on the right, but certainly a trend toward improvement. You can see a little bit of daylight starting to happen here at the 2-year mark. And so certainly in this context, we're seeing disease-free survival benefit for Pembrolizumab over placebo. And so thinking through, and there's a PDUFA date on this around December 10th, so about a month from now, we're seeing lower levels of grade 3 or higher toxicities. We are seeing improvement in disease-free survival rates, and then in potential extend for overall survival, although that data is not quite mature yet. I think on the risk side, we are still thinking about severe toxicities can be life-threatening, and then there's a cost to patient and payers, as well as the IV treatments every 3 or 6 weeks, so your patients are coming in a little bit more than they would otherwise. But certainly things to take into account when we're thinking through whether Pembrolizumab is the right treatment for your patient. It certainly depends on their patient preferences and priorities and goals for treatment. All right, I wanted to kind of take you through a couple of other studies that are currently ongoing. This is the CheckMate 914 study, which is also in the adjuvant setting, randomizing patients with high-risk resected renal cell carcinoma to either Nivolumab with Ipilimumab or placebo. And there's a third cohort as well being treated with Nivolumab monotherapy. This Prosper has been a trial that's been accruing in the cooperative groups for several years now. It recently finished accruing, and so it's a highly anticipated, I would say, trial, phase 3, randomizing patients to either an upfront dose of Nivolumab followed by nephrectomy and then adjuvant Nivolumab maintenance for about a year, or nephrectomy alone without perioperative treatment. And so I think we are all anticipating the results of Prosper, but pending enough follow-up, I would hope in the next few years we'll have that data. All right, and then thinking through multiple trials are ongoing in the neoadjuvant setting, and this is where we're taking really promising strategies, either with TKIs or TKI-IO combinations, and moving them more in the upfront setting, even pre-nephrectomy settings. And so all of these are phase 2 trials ongoing of either a TKI on its own or a TKI with immunotherapy combination. Most of these are either single or 2 or 3 centers and less than 40 or so patients. All right, what are our ongoing studies in advanced RCC? And this is where Monty was highlighting our combinations with novel therapies, first-line treatment selection, and evolving trial designs to try to optimize our comparator cohorts and think about these standard of care immunotherapy-based treatments as we go forward. So similar to what Monty showed you earlier, these are sort of next-generation first-line trial designs, I like to call them. And all of these treatments are randomized against an immunotherapy-based cohort here that we show you in the orange. And all of these trials are currently ongoing. The only one that's completed right now is the Cosmic 313, which is a triplet with Ipilimumab, Nivolumab, and Cabozantinib. We talked a little bit earlier about PDIGREE. It's more of an adaptive design based on 3-month responses, but randomizing patients to either Nivolumab or Nivolumab with Cabozantinib. There is a triplet study based on the CLEAR trial, Lenvatinib with Pembrolizumab, but adding belzutifan in that triplet. And then finally, in the cooperative groups, the PROBE trial is looking specifically at the question of consolidative nephrectomy. All of these questions, I think, are apt and really timely to think through as we get into these next generation trials. For the PDIGREE study, I mentioned we're taking patients and treating all patients upfront with Ipi and Nivo, so building off of the CheckMate 214 data that we saw a 5-year follow-up for. In terms of patients' responses, so adapting treatment to their 3-month responses, anyone with non-progressive disease or non-complete responses will be either randomized to Nivolumab with Cabozantinib or Nivolumab alone. And this is the study that is currently ongoing. It's about halfway accrued across the country, and in large part thanks to investigators around the country. And so, whoops. This is the next study that we wanted to highlight. This is the triplet that is really building on what we've learned from the CLEAR trial, so Lenvatinib, Pembrolizumab, and belzutifan added in, versus Pembrolizumab and Lenvatinib as the doublet. And then there is a novel, the Merck's CTLA-4 inhibitor, in addition to Pembrolizumab and Lenvatinib. So we'll see how much the CTLA-4 inhibition is adding versus how much the HIF-2 alpha inhibition is adding in this upfront setting. The Cosmic 313 just finished accrual earlier this year, and it is looking at the combination of the triplet of Cabozantinib, Nivolumab, and Ipilimumab versus Nivolumab and Ipilimumab. So how much does that Cabozantinib add early on? And then finally, PROBE is the question of whether consolidative nephrectomy at the timing of it. So everyone on this study, and it's a cooperative group trial that I think we're all very interested in, run out of the SWOG cooperative group, but everyone is started on a immunotherapy-based combination and then randomized to receiving consolidative nephrectomy or continuing their systemic therapy. Lots of interesting questions that we'll answer with this, and also have a lot of tissue to be collected with the consolidated nephrectomy that I think will answer a lot of biology questions of who is responding versus who is not. All right, we harken back a little bit on the IL-2 pathway and thinking about the high-dose IL-2 days when we saw some patients with very long tails of the curve, if you will, patients who were treated and cured with a very highly toxic treatment. So can we make IL-2 easier to tolerate? So we saw the data from PIVOT-02, which was a pegylated form of IL-2 called bempegaldesleukin with nivolumab in combination, and we saw an objective response rate of 71% in the first-line setting. So PIVOT-09 also just finished accrual. This was a phase 3 study that randomized patients with advanced renal cell carcinoma to either nivolumab with bempegaldesleukin or the investigator's choice of either sunitinib or cabozantinib. So I'm personally looking forward to seeing what the benefit of adding the pegylated form of IL-2 is doing in this particular setting. All right, some thoughts around challenges as we think through immunotherapy resistance and sequencing. We're talking about what's next and how do we sequence our treatments now that we have multiple active treatment combinations. And I think it really depends on the patient in front of us and the timing of their resistance. We certainly have many novel combinations and the ability to optimize our combinations versus toxicities. So we wanted to highlight a couple of ongoing data points and also trials to help answer the sequencing question. So the first is highlighting the data from COSMIC-021 that Monty led with Niraj, and we saw the data in both clear cell kidney cancer here on the left and in non-clear cell kidney cancer on the right. COSMIC-021 is one of these basket studies using the combination of cabozantinib and atezolizumab in multiple disease settings, and I think has been really helpful in terms of defining patient populations where this combination might be effective. So we certainly saw a lot of disease control. So clear cell kidney cancer, all but 2 of these patients had decreases in their target lesions. And so based on COSMIC-021, we now have an ongoing CONTACT-03 study that Monty and his colleagues are PIing across the country and currently accruing, randomizing patients who have had prior IO-based combinations to either atezolizumab with cabozantinib here at the 60 milligram dose or cabozantinib monotherapy, so building upon our known active treatments in the second-line setting. You saw the data about belzutifan on its own. Here we're showing you data about belzutifan with cabozantinib and the excellent disease control rate. 86% of patients had a reduction in their targets, the waterfall plot that you see here. So certainly an active combination, and there's an ongoing phase 3 study taking patients with metastatic renal cell and either randomizing them to either belzutifan or Everolimus in the refractory setting. Certainly also an interesting treatment in terms of in the refractory setting and thinking about whether HIF-2 alpha inhibition can help us salvage some responses. All right, how about other checkpoint inhibitor pathways? So we're talking a lot about different mechanisms. We've been seeing some really active data about targeting LAG-3 in the refractory setting. And we've seen some data come out in the melanoma space for the combination of nivolumab with relatlimab, which is an anti-LAG-3 inhibitor. There's an ongoing fraction RCC trial that's really looking at, it's an umbrella trial that's looking at different combinations building off of the checkpoint inhibitor backbones. And so I think once we see these different combinations in fraction readout, we'll have very interesting hypothesis-generating clinical data to take forward into changing our standard of care.
We had time in this program, which we usually don't, to really reflect on the forward-thinking landscape in renal cell carcinoma trials that are ongoing. One thing that we don't see is biomarker-based designs. We talk about it, theoretically. Do you see that happening downstream, or is it a bit of a pipe dream?
Well, I think there is already one that's designed. I think Brian Rini is leading this, the OPTIC trial, where, depending on the signature, patients get either nivo-ipi if they're in the 5, 6, 7, that 7 signatures from the Emotion 151. And if they're in the first 1 or 2 signature angiogenesis-driven disease, they get, IO-TKI. So I think that's That's one option. But you're right. I think a lot of what we need is when we see a patient who is treatment naive, even later on after disease progression on first-line therapy, what is driving the disease and what therapy should we select? I mean, I think this is still an area of need, an unmet need, and we don't have that yet.
Absolutely. I think even Brian would concede it's more hypothesis generating. It's a small 60-patient trial, so it'll be interesting to see how it pans out. But important effort nonetheless. I totally agree. And Tien, since we're wrapping up right around the hour here, I'll close with my favorite question, which came from the audience here, which is, how do you treat papillary renal cell carcinoma?
I think we take the PapMet data and we really use that in papillary renal cell setting, Monty, and you led that trial in the cooperative groups. We certainly treated a lot of patients on it, but showing improvement in terms of untreated papillary renal cell carcinoma, improvement in cabozantinib treated patients versus sunitinib. So certainly my go-to in the first line for papillary renal cell is cabozantinib.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/XZJ860. This educational activity is supported through medical education grants from Aveo Pharmaceuticals Incorporated, Bristol Myers Squibb, and Exelixis Incorporated. This activity is certified by Medical Learning Institute Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.